All right, this is the second lecture, so this is the part 2 lecture of visual diagnostic challenges. I think we did really well on the first group, and just because you don't know what the ultimate diagnosis was, you just need a method, a process of working these patients up to try to get to the right answer, and it doesn't necessarily have to be you that makes the final diagnosis. You can get ophthalmology, get general surgery, get rheumatology, get infectious disease involved, and help you make that final diagnosis. It's just you don't want to miss these things and send them home. So, case number 1. This is parents who bring in their 10-month-old because he turned blue. Now, the mother says he's been in good health, but she noticed that he was breathing quickly and got discolored. She noticed no recent fevers, no recent runny noses, coughs, nothing to suggest that the child was sick. She's worried that he might have swallowed something, but she didn't see that happen, right? So we have to be careful about that. I think he swallowed something, but she never witnessed that happening. Now, this is a full-term spontaneous vaginal delivery child. There's no history of congenital heart disease. The child's never been hospitalized. This is a well 10-month-old. No sick contacts. Sure, it's been a bit fussy. This is the age when they start becoming, I call upside-down beavers, because they get their 2 little bottom teeth coming in, and they look like upside-down beavers. So, it's been a little fussy. The cheeks are a little red, that kind of stuff. And she's been using some ice to help and some over-counter medicine that a friend gave her for treating teething. You go and look at the child, and it's blue, centrally, like around the mouth. It's blue, breathing rapidly, but not the, you don't see the indrawing, the tugging, the accessory muscle use, but rapid breathing. Child's afebrile, so you're not picking up a fever. Normal heart rate, don't hear a murmur. Feel the belly, there's no big spleen or liver. No edema in the extremities. The oral pharynx looks fine. You see those teeth coming in. Look in the ears, don't see anything. Eyes seem normal. Hook them up to the monitor because they're blue and their SATs are 85%. So you have that monosynaptic reflex where you just hit the knee, goes in through the dorsal column, back out, put the oxygen on, right? Nothing happens. Well, nothing happens meaning the O2 level doesn't go up. So SATs are still less than 90 despite oxygen. So you order some blood work and the nurse draws some blood and goes, look how dark that is. So the blood's really dark. So what other information do you want from your good history? Excellent. Top of the class. Where was that coming from? Okay, you'll get a prize, yeah. All right, so so what medications were they taking? And it's benzocaine. Benzocaine. Any other history that you'd like to get? Pardon me? Yeah, like just a basic history of, it's a 10-month-old. Is it growing? Is it feeding? Is it eating? Is it thriving? As you would expect, right? So that basic stuff. Even in the notes, it didn't say, hey, I'd want to know their vaccination status. That's just part of the routine. I'd also be looking at the behavior between the parents, between the two parents, and between the parents and the child, because we always have to, in the back of our mind, be thinking of abuse, unfortunately, right? You got to be thinking of that. So you're just always, you're walking in there, your radar's up and your clinical gestalt is on. It's hard to turn it off sometimes, right, when you're out in the public, right? But you're like just looking at how they're interacting. What's going on? How's the child doing? Those types of things. I'd be asking about family history of congenital heart disease. Has there been some genetic abnormalities running through your family? Those types of things. 3 possible causes. So we have 1 possible cause, a toxic exposure or the medication, right? What else? Aspiration, yep. Could have, I missed a case of, a child with a runny nose, and they weren't blue, right? They weren't hypoxic, but we're not getting chest x-rays on all little ones now to diagnose pneumonia, and had been running a low-grade fever and stuff. And of course, I had them come back, or they came back the next day as instructed if they're not better. And then we got the chest x-ray, and then I saw the coin, right? But we're not supposed to get chest x-rays routinely on every single child to rule out pneumonia, and I had treated them for pneumonia. So yeah, a foreign body, yeah, absolutely. Congenital heart disease with a right to left shunt, and the tetralogy of Fallot is one of those ones where, they're going to be blue. And if you put the oxygen on, they don't get better, right? Because the blood's not going to the lungs to get oxygenated, so it wouldn't get better with supplemental oxygen. So looking for congenital heart disease, infectious causes as well, right? A hypoxic, blue, tachypnic, tachycardic child, you might want to go, okay, could this be some kind of infectious process starting on? So you know what's wrong with the child, right? What does the child have? Methemoglobinemia, yeah. Methemoglobinemia caused by the over-the-counter benzocaine product. And children under 6 months are susceptible for this. You can also see it with other medications, nitrates, dyes, local anesthetics, sulfa drugs, pyridium, dapsone. There's a number of different drugs that can do this, but the tip-off for this was the teething and the oral gel that they had gotten from a friend, from a pharmacist who said this is good for teething, right? So that came up in the history. You can get acquired hemoglobinemia from these medications in infancy, but you can also get it from severe gastroenteritis. Did not know that. Congenital methemoglobinemia can happen, and it's usually it is an autosomal recessive disease that's benign, so I haven't stored that in long-term memory either. The pathophysiology for this methemoglobinemia is that you get the ferrous iron, right, Fe2+, goes to ferric, 3+, and 3+ doesn't carry as much oxygen. Ferric doesn't carry as much oxygen as ferrous. Okay, so it can't hold as much oxygen in the hemoglobin and transport it around the body. And one of the key tip-offs was that chocolatey looking dark blood. I'm getting head nods over here, even though you're yawning at the same time. I'm getting are you live tweeting it now? Because you can tweet my lectures if you want. But yeah, no, I was getting either that or she was like agreeing with me or falling asleep. So yeah, you can get this chocolate-looking blood. It's very dark. So the pathophysiology is that oxidized ferrous from ferrous to ferric. Now, don't be fooled by your blood gases, though, because your blood gases will be normal. Because what the blood gases are measuring is dissolved oxygen and CO2 in the plasma. Yes? Some do, and you have to ask, though, for others. So it can't necessarily... I don't know what your system is, but it's not necessarily. So I don't want you to be fooled and it doesn't pop up. But if it pops up and it says hemoglobinuria, wow, that's great. Boom. Yeah, no, it's nice when it works like this. But sometimes they can show up in an urgent care clinic or in fast track and not be as obvious, right? When they come running in and you look and it's like, and you start going like that, yeah. Absolutely. Yeah, absolutely. Yeah, no, absolutely. Yeah. So the symptoms in this child range based on the percentage of methemoglobinemia, right? So if it's less than 10%, they can be asymptomatic, dosing with this benzocaine on the teeth. But, up to greater than 70% death, right? And so it goes through a spectrum on that. Makes the diagnosis, you get your co-oximetry of oxyhemoglobin and methemoglobin, and it can distinguish that on co-oximetry. The clinical clues, though, are, of course, the cyanosis that didn't improve with oxygen, but you can still think congenital heart defect with that. And the treatment is supplemental oxygen, IV hydration, and in the severe cases, we give bicarb. But I would be reaching out to my pediatric emergency medicine colleagues long before this and getting them on board early, so we're treating this child as best we can and saying, do we give them bicarb or not? Like, would you give them bicarb or not? We've already got IV access, we're giving fluids, we're giving supportive care, they've got supplemental oxygen. I'm doing my ABCs and I'm not doing my T for CT. looking at. And then, poison control. You guys have a poison control system. I'd be picking up the phone and calling poison control, and they could advise me on methyl blue if we're supposed to be giving that. And most of these times when we get these toxidromes, that's what I'm doing. I'm getting a call to poison control and following through, and it's a great educational experience and a reminder for me for these toxidromes. And that's why they have these systems. We get, I don't see a lot of these cases, the methahemoglobinemia, but being in a northern climate, carbon monoxide poisonings and stuff like that, that's much more common. Yeah, wood burning stoves, the heater's gone off. That's when you're asking about, hey, how are the pets doing? Because, they sits, right? The gases sit, and you want to know, is everybody in the family sick? The baby's the sick one that's lying on the floor or something, or the dog and the cats that are close to the ground, they're the sickest, right? Those types of things. So yeah, I see much more carbon monoxide poisoning than I do this. Case number 2, a 26-year-old female with a history of substance use disorder. She's injection drugs, and she presents with fever, malaise, rash for the last 4 days. She is injecting heroin intramuscularly and has an abscess on her arm. It's in the deltoid region. You do vitals. She's febrile, hypotensive, and tachycardic with a normal O2 sat. She looks sick. And when you go to do the chest exam and stuff and expose, you see this diffuse scarlatina form rash on the trunk and the extremities, across her abdomen, on her chest. But you don't see any evidence of septic emboli. What are they called? Roth's Janeway lesions, and I think of Star Trek Voyager when I think Janeway lesions, but that's just me. And then the Roth spots and stuff. You don't see evidence of septic emboli. So what's the most important thing to do? I don't like those questions. Because usually when this happens, it's like, I'm walking in, I need a CBC lights, let's get 2 large boy IVs, let's do the septic. What do you mean? What's the most important thing to do first, right? But what are you going to do with this patient? Work them up for sepsis, right? So I find this question a little artificial because they say, well, the most important thing is this patient is in shock and you need a fluid bolus. Yeah, well, before I give the fluid bolus, don't I need an IV? Aren't I going to get a draw at the same time when they're starting the IV and they can do the draw off the same line? So it's all happening at the same time. So you're going to do a septic workup on this and draw your septic biomarkers, but you're also going to get your cultures, right? And then you may want to, after you give that fluid bolus, and this is the time where I'd be going, oh yeah, the 30 cc's per kilogram in an otherwise young, healthy person that doesn't have a history of, really bad congestive heart failure and big swollen ankles and stuff like that, using my clinical judgment, yeah, they need fluids. And as a 30-something-year-old, they can tolerate a lot of fluids. So 30 cc's per kilogram, give them the fluids. Maybe give them some antipyretics. Cause? It's pretty obvious, right? What's the cause of this? Sepsis, right? Yeah. And this is the toxic shock syndrome that patients can get, where they have an infectious source, so they get the fever and the rash and the shock and have a shooter's abscess is what it's called. So they've done that injection into their deltoid, they've got an abscess there, and it creates this toxic shock syndrome, which is a special type of sepsis, because it's usually involving staph or strep that produces an exotoxin that causes all of these cascading problems that has a high mortality rate. It's multi-system involvement from GI to neuro to renal, hematological, muscular, and like I said, it's staph or strep producing an exotoxin. And I remember this because early on in my career, this first hit the mainstream media when it was tampon-related toxic shock syndrome. And I'm seeing some people nod because they've been practicing long enough to remember that. And you'd get these young, healthy women, and it's like, oh my God, they're septic and they've got this rash and they're not IV drug users. What's going on? And it turns out that these super absorbent tampons that were being produced at the time could produce this toxic shock syndrome. But you can also get toxic shock syndrome from other packings. So if somebody's post-op and they've had some kind of surgical wound packed or something like that, you can get it with nasal packing, right? So how long do you leave that in? And if they come in and they've had that nasal packing and, oh, I didn't know I was supposed to come back, and a week later they've still got that string coming out of their nose with that nasal, these things can happen, right? And they come in super sick and it's toxic shock syndrome. How's it treated? Well, it's giving, like sepsis. What do we do for sepsis? We give fluids, we give antibiotics that are appropriate, broad spectrum to start with, but like antibiotics that we think, targeted to what we think the thing is. Source control, right? And in this case, it's pretty obvious that there's an abscess there, but I'd still be checking for tampons and stuff like that. Could be fooled, right? But source control, remove the source. And then vasopressors is listed as part of the septic protocols. But the prognosis isn't great. The prognosis is not great. Somewhere around 50% if they end up getting toxic shock syndrome. Okay, case 3. This is the third. Oh, yes, sorry, in the back. What did they say? Yeah, they do recommend ×3 cultures. I couldn't find really great evidence for ×3. And I guess they really want to identify the bug. And, each time you take a blood culture, you could have a false negative. And so if you have 2 false negatives, that's be rare. 3 false negatives would be really rare. So they really want to identify the bug. I don't know. Yeah. And usually it's the lab coming going, do you really want 2? Right? That's usually, and I'm like, oh, let me check. Right? And so in this case, and thanks for bringing that up about getting 3 blood cultures, they do recommend getting 3 blood cultures. I can go back and look up the evidence that supports that and see how strong it is, because it might just be a consensus statement with regards to doing that from the Infectious Disease Society of America. But the honest answer is I don't know. I don't have that in my head, but I can find that out for you. Okay? All right. And the last case. Okay, they've got a picture of an eyeball and an ECG. So, 32-year-old female presents to your ED with agitation. Per her boyfriend's history, she started acting strangely in the preceding hour after drinking some herbal tea, and she was drinking this herbal tea for a cold. So she was using some herbal tea to treat a cold. She has no prior medical history to speak of. She's not on any chronic medications, no prescription drugs, no psychiatric history. And the boyfriend doesn't, it was tea. She said she was having herbal tea. Yeah, that was the extent of his history. But you go to see the patient and you notice that she's alternating between laughing and crying and being very emotionally labile. And in the notes, it says that she was acting hysterical. And since we talked about language matters, I think that it's important to say, hey, that's not good. Hysteria, it's from the Greek meaning uterus, and traditionally in the 19th century, it was a woman is emotionally labile because she has a uterus. So I've put a line through hysterical and just put emotionally labile, vacillating between, laughing and crying, laughing and crying. Febrile, 103.2, tachycardic, 145, hypertensive, and you look at her eyeballs and she's got that like belladonna look, right? Those big, big pupils, right? Belladonna, beautiful woman, that's what belladonna means, right? And she's got the big pupils, and you get that ECG. So, what other information or exam finding do you need to do to determine the next step? Well, certainly it looks like a toxidrome, right? Right off the bat. But I would be examining the skin. Is it warm and dry? Or is it moist, sweaty, right? Am I talking anticholinergic, sympathomimetic? Where am I going with this? Listening to the lungs for wheeziness. Listening to the bowel sounds. Anticholinergic, you probably won't have bowel sounds, right? And in this case, the patient has absent bowel sounds, and the skin is warm and dry. So that's pushing you more towards the anticholinergic side of things. Anybody want to interpret the ECG? No? Okay. No. What's the ECG show? Hey, it's tacky. Stripes and plaids. No, it's tacky. It's fast, right? So it's going fast. What else? Get the easy stuff. Yes, I saw you doing this. What's this mean? I crush your head, I crush your head. No, what's this mean? Wide QRS, is that what you mean? Yeah, that's what she means, wide QRS. Anything else? Sinus tach, wide QRS, and it's leaning to the right axis deviation, okay? So the two possible causes are sympathomimetic or an anticholinergic syndrome, because they'll both cause dilated pupils, agitation, altered mental status, tachycardia. But it's the warm, dry skin and the absent bowel sounds that would sort of nudge you and implicate an anticholinergic processes going on. So what's wrong with the patient? Well, there's got to be something in that T, right? I mean, it was correlated temporally, right? And there are certain herbal teas out there that have something called datura leaves. And datura leaves is also known as Gibson weed. It's a natural antihistamine. So this brings up the thing that, this natural fallacy, the logical fallacy about it's natural. My usual response is dog poop is natural, and I don't take that 3 times a day. Uranium-235, oh, that's natural. Cyanide, arsenic, natural, right? But not necessarily good for you. So just because something is natural doesn't mean it's healthy for you and that it won't cause some problems. So this natural herbal tea with antihistamine properties has caused this anticholinergic syndrome. And so it doesn't matter if it's natural or not. So what's the mechanism? Well, it's the muscarinic cholinergic antagonism. They get the skin flushing, the anhidrosis, hyperthermia, so the fever, and the altered mental status. So what can you do to confirm this? Well, there are no specific tests for this. I mean, you're going to get your CBC, right? You might start looking for sepsis, they coming in, fever and tachycardic. Your EHR is going to put a flag on it for you, right? Should you be automatically giving this person 30 cc's per kilogram, though? And that's where this comes in. Wait a minute, I don't think this is a sepsis picture, right? But your EHR might flag that as that. Getting some things looking for rhabdo because of that hypermetabolic state that's going on. You'd want to see the person clear up and make sure that this wasn't some intentional overdose, right? If there is a psychiatric issue going on. I would get a drug screen looking for salicylates, because salicylates will cause this. We used to see this, and maybe Rick, you could comment on this. Back in the 70s and 80s when we had aspirin for migraine patients, and migraine patients inadvertently would overdose on aspirin and come in this similar toxidrome. Wouldn't you see that from time to time? Yeah, and that's the last case that I saw of a patient presenting like this, and it was a handover, and the handover was, she's agitated, she's going from delirious and stuff like that, I don't know what's going on, and we've got blood work pending, and it turned out to be an ASA overdose by accident. It wasn't intentional, and we addressed it that way, but that's where I dug into the literature and found out that this was much more common back when ASA was the drug of choice. And that sort of went away when there was this huge thing with Rye syndrome in kids, and aspirin products were more pulled off the shelf, and people were turning to acetaminophen and ibuprofen and those products for their aches and pains and fevers, headaches, those types of things. So certainly also historically, and I'll look for the, let's say the more mature people in the audience, TCA overdoses. Right? Before we got the SSRIs, people were on these TCAs and would overdose on TCAs and could come in with that tricyclic antidepressant looking very similar to this. Their blood chemistry, they'd be acidotic too, and sometimes profoundly acidotic. So the treatment for this is supportive therapy, IV fluids. You can do external cooling, monitor the patient. But this is the time where I'd be picking up the phone and calling my poison control center, and they have an algorithm, they send it over to us, and we follow that, and we keep the patient for the duration that they recommend, and get the appropriate additional blood tests that they think we should be following. But it's that recognition that, whoa, you've got a fever, you're tachycardic, you're not looking good, and you're mentally altered. That patient's not going home, right? Like, we're actually going to go, hey, I think something's wrong here. So even if you didn't right off the bat get the herbal tea thing, you know sick, not sick. And then you work through the process. So it does have here about, yes, she does have the history of ingesting herbal tea, but asking about other prescription medicines and, the now rare tricyclic overdoses and stuff like that. And that's one of the times where you can use bicarb. Because bicarb, has really gone out of favor, for things like DKA and other things. You have to be profoundly down, but it's still there for TCA overdoses and for ASA overdoses as an effective therapy for that. These patients can get cardiac toxicity, they can start seizing and stuff like that. So that's why they're staying, right? They're staying, we're watching them and maintaining them. Any questions about that third and final case? Okay, what time are we at? 8:59. I just want to show you, my wife just texted me and said, yep, we're on our, okay, Uber's picking us up at 9:15 on the dot. Please don't be late. And the only response is, yes, dear. But I want to thank you because I have to leave. It's been a pleasure. As the week's gone on, we got to get to know each other a bit better, got to talk a little nerdy, give out some prizes and stuff like that. Usually at the end of my last talk, I just say, if you need to email me, email me. My email is THESGEM. So that's the Skeptic's Guide to Emergency Medicine. Email me if you have any nerdy questions. I love fielding nerdy questions. Okay, it's the sgem@gmail.com, right? And then the last thing is thank you to Dr. Bukata, who's been putting on this course and educating, people, clinicians, to make sure that patients are getting the best damn care possible because of his efforts and his education. So thank you.